As I mentioned earlier, my name is Julie Lucero. I am a doctoral fellow with the Robert Wood Johnson Center. I am a student in communication and journalism studying health communication, and it is my absolute honor and privilege to introduce Dr. Tricket. The work that I am involved with Dr. Wallerstein, we very much use the work of Dr. Tricket, and so this is very exciting for me. I'm going to briefly introduce him because I'm sure you'd rather hear him than you would me. So very quickly, Dr. Tricket is a professor in psychology, and he's also the chair of the Community and Prevention Research Division at the University of Illinois at Chicago. His work has focused on community psychology and the development of the ecological perspective, and he also focuses much of his writings on social context, culture, and community-based participatory research, as well as interventions. Most recently, he has published an article that talks about form versus function, which is awesome, whether we focus on what the function of an intervention is or whether we focus on the evidence-based form and we really just follow, deliver a curriculum the way that everybody else has. He also recently, in the past 20 years, has focused on public schools and their role in acculturation of immigrants. And I think that's what we're going to be hearing today. So without further ado, Dr. Tricket.
Good morning. Let me see if this works here. I'm actually not going to spend a lot of time today talking about the work I've done over the past 15, 20 years on immigration and acculturation of Soviet Jews, Vietnamese, Somali communities, or the measure that we've developed that differentiates language, identity, and behavior as differing acculturative processes occurring at different rates in different life domains for different immigrant and refugee groups. I'm happy to spend more time about that sort of informally, but time is really, I've learned of the essence here. One thing I've made a life, if it wasn't for context, I wouldn't have had a career. I mean, context gives meaning to everything. It wasn't until we had public schools, for example, that the concept of learning disability became something people thought about. Social organizations can indeed create diagnoses because they create situations for people that they have to cope with, and when they don't cope with them, we call them something. So context to me is very important to me. And part of that is I want to both appreciate Dr. Levy's comments, but let him know there are no wildebeests in Garrett County. I've been there, but you can't do that there. There just simply aren't. But there are several things in the comments before that I wanted to sort of use as background to what I want to say today about paradigms. I want to talk the language of paradigms. We Knew the Future All Along was something that maybe some of you read. Did any of you read that? It was sent out to us. It was basically an example, I think, of the love of the medical model approach to understanding human behavior. And the premise of that paper was basically that we design studies in such a way that we're pretty much assured of what we're going to find. And if we do that, we both feel good about ourselves, we publish, but we also really maybe didn't need to do a lot of the studies in the first place. And part of the work that I'm doing with a graduate student now at UIC is to look at a meta-analysis of a very successful, by meta-analytic techniques, survey of universal school-based interventions, where instead of looking at effect sizes, we're looking at the percentage of hypotheses confirmed in these studies. And in a report that touts all kinds of positive benefits for school-based interventions more generally, 46% of the hypotheses were confirmed. So you get a very different portrait of studies, depending on the outcome criteria you use. We're also doing an external validity analysis of that same body of literature, using heavily but not totally the work that Larry Green and Russ Glasgow have done on external validity, and you get a very different picture about what we know if you look on external validity terms versus internal validity terms. So one of the things I got from the discussion of the data in the earlier talk was that we actually know a whole lot less than we think we do. That there's so many different ways we can manipulate, organize, torture information, that we should be quite careful about what we say we know, particularly when it involves not just science, but economics. One of the issues about evidence-based practice I'll briefly touch on later has to do with the scientific implications of having a sort of an inherent conflict of interest in what you're doing. So what I want to do today is talk about the alternative to evidence-based practice perspective that I've been working on for decades, an ecological perspective, a way of thinking about community interventions, lay that perspective out, and see where we go from there. And the basic thing I want to start with is the paradigm idea. All of you are familiar with it, but it basically forms the set of assumptions. It's the assumptive structure under which we operate, and those assumptions themselves are not subject to scientific inquiry. They are assumptions that we go on. You're familiar with it. You use this language all the time, probably. In my program, it's known as the P word. It's just because we sort of try to figure out how we mean it when we use it all the time. But paradigms affect how the questions we ask, and that was evident in the different kinds of questions in the previous talk about the different questions asked of data, which resulted in different kinds of analyses, which resulted in different kinds of conclusions about that same set of information. How we study it, whether or not we think the quality of life is as important as the quantity of life, for example. It's a paradigm decision. It's not subject to, it's an assumption. How we interpret our data, it goes back to the previous talk, very nicely illustrated. And so what I want to do is just talk a little bit about my understanding of the sort of love of the medical model that you so indelicately phrased earlier on. And see how that applies to the issues of health inequities, which derive from social structural conditions of which there is sufficient evidence. And there's a second premise I want to work on, which comes from our good friend Albert Einstein. It can scarcely be denied the supreme goal of all theories to make the irreducible basic elements as simple and as few as possible. The underlining is mine. Without having to surrender the adequate representation of a single datum of experience. And so that quote has been summarized by some people to say that theory should be as simple as possible, but no simpler. And the but no simpler is, I think, where we're at now in the discussion around health inequities. Are the theories we've been working on a little too simple to capture the phenomenon and the concerns that we have? Now, the origins, as I understand it, of the evidence-based practice movement are incredibly noble and important origins. And they basically are phrased in a way that allows both scientific expertise and local clinical judgment to come into play in making decisions about individual patients. There's never any particular formula that I've found that sort of suggests what should come into play. But somehow there's the belief that they both can interact in treating particular patients. And it was a reaction against what turned out in many cases in the history of medicine to be basically fundamentally false knowledge about things that were then transmitted. So there's a very important function that evidence serves in general. And in part of the documents that we were sent, I think there was a phrase that talked about the, quote, rhetoric of evidence. That is, in terms of what goals, for what purposes evidence was used, that make us need to think about such questions as what constitutes evidence, which is a paradigm-related phenomenon, and the more political question about who gets to decide what constitutes evidence, which has to do with the relationship of science and state. So the idea then behind evidence-based practice is one I think that makes perfect sense in principle, if it allows individual knowledge to interact with scientific information. And the way it's been operationalized has taken some of the individual choice out of it in some areas. You're familiar with you know all these things, right? Maybe I should just go on. You have your hierarchy of evidence, you have the randomized controlled trial, and the emphasizing of internal validity, which is a value choice, as much as anything else. The emphasizing of internal validity related to that, the idea that knowledge is cumulative and indeed generalizable. And it's not at all clear how one decides within this perspective how generalizable a phenomenon is. And in the programs that I've seen, if you can do it twice, you're in good shape. Now, there's something else which this paradigm does, not as a function of the paradigm itself, but as an inadvertent consequence of randomized controlled trials, which are so much easier to do in individuals rather than higher levels or the level of analysis. So that there's a push to work to sort of look at individual goals as opposed to structural goals, which is not inherent in the design, but it's inherent in the pragmatics of conducting the work. I think that's an important, when we're talking about structural issues, I think that's an important aspect of this particular perspective to focus on. And of course, I think it reflects the laboratory traditions and the traditions of the natural sciences, out of which social sciences came a couple hundred years ago. Anne Oakley has a wonderful book called Experiments in Knowing that traces the history of sort of the physical sciences and paradigms in the physical sciences and the social sciences, and the hopes hundreds of years ago that we could have laws of society comparable to laws of physics. I think that for reasons I want to tell you right now, I think that's not quite as likely as people thought. The reason I want to tell you right now, I'll tell you right now, I'm going to say it again later, but one of my favorite quotes is from a wonderful psychologist, Lee Cronbach, who is known for being a good methodologist, an excellent methodologist. And one of my favorite quotes, he was talking about the role of social science as contrasted with natural sciences, and his quote, which I will put up on the screen at the end of this talk, is that while particles are attracted to each other, they don't fall in love. And so I think a lot of the psychology and a lot of the community issues, a lot of the paradigm, the structural issues have to do with people's ability to fall in love, to create cultures, to create organizations, to reflect on what's said to us rather than react in a kind of automatic way. And that is not part of this particular perspective. Nor is the relationship of the researcher to the researched part of this particular perspective. We are indeed error variants or sources of potential bias that we go to great lengths to exclude from our work. And in several areas, certainly education is the one with which I'm most familiar. Paradigms have consequences, and there's Carol Weiss coined the phrase imposed use of the way in which evidence-based programs and lists are generated and used to direct the activities of people for whom they're intended. So policymakers locally have to adopt or somehow deal with issues of evidence-based practice. And there's a sort of half-full, half-empty perspective on this. The half-full involves the degree to which it's very important to know what scientists have produced in terms of evidence. The half-empty is that it's very important to understand the lack of potential external validity of so much of the evidence that science has produced. And that's sort of the bind, I think, that you get into around these kinds of imposed use issues. And as you can see, the regulations around this have been adopted by many, many different kinds of agencies and around different kinds of behaviors: violence, prevention, teenage pregnancy, reduction of HIV, drug abuse. I mean, the federal government spends billions of dollars every year on drug abuse, just as a short aside. And that's still the most popular program in the drug abuse area is DARE. Now, there are people who think DARE has bad consequences, or some people. There's a lot of evidence that suggests DARE is not the next best thing to sliced bread when it comes to drug education, although I don't think there's anything that they have strong evidence that is the next best thing to sliced bread. But that focuses totally on individual level outcomes. It neglects totally all the structural issues that contribute to the availability of drugs, to the escapist kind of issue related to drugs that was brought up earlier with respect to alcohol as a kind of anesthetic rather than something else. And there's also something in this language that makes me very suspicious as a social scientist. What philosophy of science do you know where you can say something is scientifically proven? I just don't know of any, but that's the language. And I worry about that. I hear that in ads when people want me to, buy stuff. But I haven't heard it so frequently in the scientific community, and it makes me a little leery. And there have been various kind of socio-political questions that have risen. There's a huge literature contesting all these aspects of evidence-based practice, by the way. There's thousands of papers have been written about this. One is, what does it do to the autonomy of individuals who thought they were seemingly competent before they were made to use a particular practice? And that comes up in the No Child Left Behind literature. And there's a nice paper out of Harvard School of Education about images of teaching in No Child Left Behind. No Child Left Behind, by the way, is also a really good example of how policies trickle down very differently in different levels, and sort of making policy does not have anything particular to say about how it's going to be enacted in any particular place. There's a website, I think I found it. I teach at a university, so sometimes I make stuff up. Unlike those of you who don't teach at a university. But I think I found a website where there were 52 different reports or whatever, or 50 different reports from different states on how they'd managed to deal with the implications of No Child Left Behind and adapt them to their own states. So a single policy sort of trickles down in very, very different ways in different places. And I already raised the issue about what happens to science when economic interests are involved. I mean, it's hard. And there's a lot of instances in the drug literature, about sort of suppression of findings, things more serious than that. But there's also the basic issue of how we can deal with the potential conflict of interest when, if my program succeeds, it has a chance of making me money, which is not a scientific sort of let's see what happens perspective on knowledge. And there are several people who have written about that and cited Foucault's work about governmentality in terms of the increasing amount of power and fewer numbers of people controlling what constitutes science. And the qualitative folks have gone crazy about this because qualitative research does not qualify on any of these lists very highly of evidence-based programs. And then there's my experience, and I think Nina's as well, the issue of forced acculturation that we've heard on various American, Indian, Alaska Native communities about being forced to adopt practices, programs that have cultural underlying assumptions that don't mesh well with the traditions of the particular places involved. So there's all those kind of issues are in the literature, socio-political issues about what happens under those circumstances. Now, the topic of social or structural inequalities, social inequities, simply refers to this. This has been talked about before, and there's a lot of evidence that indeed various levels of the ecological context contribute to all these kinds of disparities and inequalities that have been discussed. And there's an accompanying rise in the literature of a concern about multi-level interventions. That is, interventions that target multiple levels of local ecology. And here's my community psychology back. I'm talking from a community psychology background now, not a larger policy one or whatever, just so you know the limits of my framework. But multi-level interventions have multiple components that are designed to affect factors in two or more levels of the context, the ecological context, which contribute to wellness and illness with the goal of affecting changes both within and between those levels. It is not an individual level change perspective. And there have been a lot of calls for multi-level interventions, both in terms of professional fields of study. These are over a number of years: public health, my own field, applied anthropology. The Institute of Medicine, Smedley and Syme have a very nice review of that particular concern. Kellogg Foundation engaged schools of public health, did a very nice paper about 7 years ago. And in Australia, Vic Health is a similar kind of organization, has done a comparable paper on looking at the sort of upstream determinants of well-being. There's a lot of emphasis coming along for a variety of reasons. First, which you're all familiar with, is the evidence in favor of contributions to health at multiple levels of the ecology. And these are just some of the areas where there's a large literature, including meta-analyses even, about forces in the ecological environment affecting outcomes. So if they affect outcomes, why not think about doing something about them? Rather simplistic thing. There are other rationales too, is that individual level efforts do little to alter the distribution of disease and injury when they're directed toward people who already have them. And I think that was Dr. Levy's comment about one issue of related to one response about sort of the advances in medicine saying, well, just wait till they get sick and we can treat them. What that does, as you know, from a socio-political point of view, is ensure a career for the treaters. And that's one of that's the only clear implication I can. I'm not sure what it does to it certainly ensures a career for the treaters. And also, there's some evidence that universal interventions may indeed lift all boats, but not all boats equally. That is, there's some evidence particularly in some programs for young children, early development programs in schools, where indeed those poised most to take advantage of them get the most out of them. So what this can do simultaneously is increase the overall health and increase disparities. And that's you can argue about whether or not which of those goals you want to have, or if you have to choose between those two. But there is evidence that can occur, and that's when you focus interventions on individuals. It's also, though, true at the school level. A colleague of mine, Dave Henry, at UIC, has some data on a violence prevention program that finds that the mediators of the effects of the violence prevention program in the 15 schools involved in the program are not program effects, they're school effects. So the programs succeed in schools with a lot of resources. The programs don't succeed in schools without so many resources, and it's the same program. Then there's a fading of individual level effects over time that basically, the fading of individual effects over time. The opportunity costs. We're spending millions of dollars trying to change people and not settings. Billions of dollars have been spent for programs for kids in schools. We have not one piece of evidence that schools as institutions are any better as a consequence of those billions of dollars. They may be, but the paradigm has not forced the people doing that work to look at that level. Again, it's a link between paradigm and outcomes. And then there's then there's the sort of interpretive confounding of cause. If you only it's the same thing as method variance. If you only use one method, you can never disentangle your findings from the particular method you use to achieve those findings. And the same thing is true here, that if you only look at one level of analysis, you can always attribute to individuals things that may indeed be more explainable in terms of community level factors. For example, whether or not someone uses healthcare may have more to do with the kind of facilities available in one's neighborhood than one's personal qualities or characteristics. So there's a conceptual reason for looking at multiple levels. And in all these papers and all these professional organizations, there are a series of shared assumptions that they have which turn out conveniently to me to be very ecological. The first is that in trying to deal with multi-level interventions to deal with health inequities, there's a value of adopting an ecological or social-ecological perspective on behavior. And the idea of levels comes from Bronfenbrenner, I think, but I wrote Bronfenbrenner light because most people don't understand Bronfenbrenner when they invoke him. A fundamental premise, for example, being that in his perspective, levels are interdependent and reciprocal and interactive rather than independent, the way they're treated in most of the literature that has been done. But also the importance of focusing on different domains. Family and school, where the typical intervention will add a family component or add a school component and sort of see them as sort of independent as opposed to interdependent influences over the outcomes. That's why I say Bronfenbrenner light. But there is the idea about an ecological perspective there. The second is the CBPR influence about collaboration, the importance of developing collaborative and empowering partnerships with relevant sectors of the community in the intervention, planning, and implementation. It's sort of a collaboration throughout perspective. The third involves goals, selecting goals that are multi-level and assessing changes in those goals at multi-levels. So the concern is to make sure that something is different in the local ecology as a function of the intervention. And it redefines the notion of sustainability away from keeping a program going to keeping resources and infrastructure in a community available for local problem solving as conditions change. It's quite a fundamental difference. Jay Schenzel has done a very nice piece of work on that. Nina, I'm sorry to sort of out you here, but you did a very nice paper on how epidemiology and community-based participatory work can be reciprocal, so be synergistic in working across different disciplines. And one of the things that all these reports talk about is the importance of multidisciplinary, transdisciplinary work, because no discipline has any sort of owns any serious social issue. It just simply doesn't make sense. Finally, there's the issue of the time commitment that all the reports and all of us talk about. Community change of any kind just takes longer than individual change and requires different kinds of resources. And there are those who've looked at the typical kind of funding cycle that we go through as a structural constraint over community change, when indeed the intent of that kind of funding is absolutely the opposite of that. So there's the issue of time and how that gets dealt with, and the need to develop new worldviews or paradigms. And this is where my life comes in a little bit, to account for the conceptual complexities involved. So what I want to do, how am I doing for time here? I haven't gotten the 5 minutes. Oh, well, as I was saying. In public health, there's been a long time recognition of shifting from, this is from Jim Frankish and Larry Green, shifting from a public to a population health, which in their definition focuses more on communities, the social conditions in communities, rather than defining people by risk factors or groups by risk factors. In our field, in community psychology, we differentiate populations from communities to emphasize that populations are can be seen as groups of independent people, but communities have their own sets of interdependence, their own sets of relationships, their own sets of organizations that have ways of dealing with each other to make it more contextual. But that's the shift of multi-level interventions, is away from the individual level of analysis to a community level of analysis. And I just want to run through briefly the perspective that's been developed in my field over quite some time. First paper on this was by my mentor Jim Kelly in 1970, which predated Bronfenbrenner by a number of years, actually. And it's the ecological perspective in my field is not seen as a theory. It's a way of thinking. It's a heuristic to guide research and practice rather than having full-blown constructs, theoretical relationships. As Kelly wrote, the ecological ideas are topics for further clarification and illustration in very specific locales. There's a very clear contextual message in this particular perspective. First premise is developing a multi-level conception of community life and contributions to health inequities. The community as a unit of analysis comes from, well, it was reflected, it doesn't come from, this preceded it, but it was reflected in Barbara Israel's and Amy Schultz's wonderful paper on CBPR that came out almost 15 years ago. And it demands a sort of coping and adaptation perspective. Oh yeah. on individual life. So the first premise is a community premise. The community is level of analysis, trying to figure out what that community is like. And to do that, we've adopted some series of ideas from field biology, which Kelly called ecological metaphor, to help direct the inquiry. I'll just briefly go over them given the time. The adaptation principle is sort of fundamental. It's sort of the demands of the characteristics of the community context. I mean, for example, what does it take in a community to get a doctor's appointment? What does it take to buy healthy food? What does it take to protect your child from neighborhood violence? What does it take to help your child from another country negotiate the multiple cultural spheres of home, school, neighborhood? Those kinds of questions, what the demands are on individuals to accomplish important survival tasks, is what is meant by the adaptation principle more generally. The cycling of resources principle focuses on the strengths of communities. It includes people with skills, people with commitments to just causes. It includes social settings in the community that provide safe havens, that provide services, that provide places to share concerns. You probably notice when every presidential season you'll find somebody up in New Hampshire showing up at 8 o'clock in the local cafe to talk to people and get a taste of the town, because that's where people organize to sort of talk about political issues, who's done what to whom, what they should be doing, and so forth. Settings are important. Events are important to celebrate cultural and religious heritage or to grieve losses. They provide a sense of community, a sense of identity. And creating events can be an important intervention goal to do that. And of course, resources are manifest or latent. You'll find the more you get to know communities, the more you'll find interesting oddballs, characters who didn't come out of the woodwork until you've had a chance to get to know the place a little better, who have really interesting skills that may indeed be very helpful to harness some part of community intervention. Third principle, the interdependence principle, is the basic assumption of systems theory, the interconnectedness of people, places, and the feedback loops among all of them. The important thing for community interventions is to focus. It helps provide a focus for looking for and caring about unanticipated consequences. And if any of you said you've been engaged in community intervention work and you've never had any unanticipated consequences, even I would think the Kool-Aid has taken hold. But to have unanticipated consequences, it's helpful to have a map for where to look. And the interdependence principle provides some way of and there are people who sort of think about doing community interventions first by bringing together stakeholders from different parts of the community and running through a kind of what would happen if this happened, what would happen in your organization, what would these kids do? So the interdependence principle focuses on sort of creating maps of the system. And the succession principle focuses on the time dimension of communities. Both history, cultural history, ways of defining problems, the changing roles of elders, for example, in Alaska Native communities and some American Indian communities. And in addition to history, the hopes of communities. In the Alaska Native, I'm talking about that because I spend a fair amount of time up in Fairbanks, Alaska, working with the Center for Alaska Native Health Research. I've had a chance to get to know some of those folks and some of those communities. But the idea that's so prevalent among research in American Indian and Alaska Native communities about cultural restoration comes from a history and to the degree to which interventions can link themselves up to the hopes of communities. The ecological assumption is that those are much more relevant and salient and able to develop some kind of particular positive outcomes and have some life of their own. So within this perspective, then, community resource development is the ultimate goal. And that's because communities change over time, populations change over time, politicians change. And communities have to have to be ready to respond to changing conditions. And programs change over time as new populations of people come in to the community in terms of a specific health-related outcome. So specific programs need to monitor, They need feedback loops. They need to have the capacity to adapt to changing conditions. And the idea then, the longer term idea, is how to make any particular intervention a longer term resource for the community. And community knowledge, community relations, community collaboration, and having a sort of portrait of a multi-layered conception of community life are the building blocks for that. So that what footprint of the intervention remains at multiple levels when the intervention ends is the bottom line. No footprint, not so good. I mean, communities deserve better, frankly. So that's sort of the bottom line about the goals. And these are just examples of, proximal examples of some of the kinds of things that have occurred in different projects, creating new settings, increasing the kinds of networks and so forth among agencies. Strengthening weak, you're familiar with the weak ties, you sociology people must know the weak ties idea, right? So, sort of the people who have connections to people outside of your network, specialized knowledge, like if you're in high school, you go to a guidance counselor because they presumably, well, they presumably know how to help you get into college, and they have special connections with these colleges and so forth. I mean, there may be people in the community whose brother for somehow married into the mayor's family. You don't know these things. But weak ties are those kind of connections that can bring in external resources to communities. And so sometimes they're an outcome. Articulating processes for the development of community leaders. Anyway, there are just a variety of different things, proximal things that one can do to indicate some footprint of the intervention after it's gone. Then there's a social construction of knowledge and the collaborative approach, which is also part of this. The idea underlying this is not a positivistic perspective on science, but a contextualist or perspectival philosophy of science, where observations are bound by space, time, and the history of role relationships among the participants. I mean, clearly, in our own lives, we don't tell everybody anything they want to know until we know sort of who they are and what they want to use it for. I mean, if we did, we should be hospitalized. And real people in the real world do the same thing. So that the co-construction of knowledge about local issues, local history, what structural issues are that need to be changed in a community is a collaboratively developed process. And it indeed is socially constructed, just like people were talking about race being socially constructed earlier. And I just want to emphasize the fundamental centrality of collaboration. I think it's a singular contribution to the CBPR movement that we in community psychology had less of a dent in for many more years, and CBPR has done a lovely job of it. But it's basically taking people who you care about and whose problems you care about seriously as sources of information, as sources of energy to help solve those problems. And the important thing here from the ecological perspective is that those relationships are themselves part of the intervention paradigm. It's the fundamental difference between the RCT perspective and the ecology perspective. And this is my character. This may not be fair, but in the hierarchy of evidence perspective, relationship. Oh, I love the phrase buy-in, by the way. This is such an economic image to describe the relationship. But in that literature, you want to develop relationships so you can do the real work. It puts you in a position to do the real work, which is the technology. In the ecological perspective, that is part of the real work. And then, so variations in collaboration, variations in kind of relationships themselves are part of the ecology because they affect processes and outcomes relevant to the intervention. Finally, there's funding. Funding is part of the ecology as well. Funding helps structure what's possible and what's not possible. The ecological demands of multi-level interventions include various kinds of resources around relationship building, community assessment, process for indigenous theory development, assessment of outcomes at multiple levels. This is a new ballgame for everybody conceptually, and I think it's a new ballgame for most of the funding organizations who have written reports on this and say that funding needs to be rethought not with specific ideas in mind at this point, but as an area of serious consideration, because they understand that this is part of the ecology of multi-level interventions. And going back to Cronbach, I'm going to finish with this. I think the two paradigms in some ways differentiate falling for the manual versus falling in love. That indeed they're different images. What constitutes the intervention is vastly different in multi-level ecological inquiry than in evidence-based practice, where the intervention is the technology or the treatment. And going back to Einstein's idea about a theory should be as simple as possible, but no simpler, I conclude that a theory should be as simple as possible, but no simpler. And hard as I've tried, I can't make that other theory complex enough. Thank you for your time.
Thank you, Dr. Tricket. We're going to mirror the exact same structure as the last presentation. So we have our brief discussants, Tennille Marley, who is a doctoral student in sociology, and Shauna Judge, who is a visiting professor in the College of Nursing.
Hi, Dr. Tricket. Thank you so much. Hearing you talk today and talk about this ecological approach to health is really nice because I feel alone sometimes. I study the sociology of health, but I'm kind of housed under the medical sociology, and I see two things as very different. So I want to thank you for just making me feel a little bit better about my work. But I guess my question is, in your presentation, you kind of, trying to look at how can we look at health differently, how can we look at things differently, and I tend to do that in my work, where I definitely take a very ecological approach to my work. And my area is primary sociology, but I also integrate a lot of indigenous knowledge, a lot of myself as an indigenous person into the work that I do. So, I mean, there's no separation between my research and self. And I think that's true for many of the fellows here. We are part of our research. We go into it because we care. So I guess my question is to you, what would you advise students who are working on the PhD, who are kind of pushing these boundaries, who are coming up against challenges? What would be your advice to us?
Do you feel free to mention the challenges?
Well, let's put it this way. The last two submissions that I put in for my work has been rejected. I think whenever I go to the sociology conferences and go to the medical sociology sessions, it's very frustrating to see very individual level outcomes and interventions talked about again and again. But I guess the challenge is how can we look at things more broadly but have our voices be heard, or our research be seen and heard and be looked at as valid? Kind of big, sorry.
This is where all of us can chip in, I'm pretty sure. I mean, I think it's important to there's a groundswell in your favor. You just got to hang on long enough. I mean, it's important to have mentors who can help guide how to frame things, how to write things, who to write for. It's important to know the literature that supports non-traditional thinking. And it's helpful, for example, if you have organizations like the Institute of Medicine write reports rather than me in terms of that kind of criteria. It's important to find out who your friends are. One of the things that I think has been characteristic of my life is I have a very different set of marginalities than you, but I suffer from them. But it's been important for me to sort of find a fight group who I could sort of derive support from and work with and get ideas from, and realize that I'm not alone, because that's a really important So my wife's is a refugee from the former Soviet Union, and when she was, I just remember one time she was doing a job talk someplace or other, and some unspeakable person, it was a very interesting work on acculturation, he says unbiasedly, but somebody in the audience get up and said, "I just think that's me-search." I mean, at that point, I don't know quite where to go with it. And she didn't know where to go with it either, because she has good social skills, so she didn't do what I would have done. But I mean, there are pockets of people. There are and influential pockets of people. The CBPR folks are coming on like wildfires, influences, I think, in public health and in sociology. The National Institute of Mental Health is having RFAs involving collaborative work. NARCH continually has opportunities for funding to try to push the collaboration envelope to try to see how much we can learn from this new way of different way of relating to people. So at one